Okay, and welcome to the Davies Use Case webinar being presented by University of North Carolina Healthcare on improving depression care. This is the Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcome and value. The Davies Award-winning use case have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from UNC Healthcare for today's webinar, Dr. Vinay Reddy and Annie Whitney. So Dr. Reddy and Annie, I will turn the presentation over to you and you can begin when you're ready. Thank you so much for joining us.
Hi, this is Vinay Reddy. I'm a family medicine physician at UNC Healthcare System.
And this is Annie Whitney, Program Manager of Population Health Solutions.
And we're here to present the HIMSS Davies Enterprise Award case study in improving depression care. First, a little bit about UNC Healthcare System. UNC Healthcare System is an integrated not-for-profit healthcare system owned by the state of North Carolina and based in Chapel Hill. We provide comprehensive patient care, facilitate physician education and research excellence, and promote the health and well-being of all North Carolinians. As you can see, we're committed to providing them high-quality care all across our state in a number of locations. As a system, as you can see on this slide, we have a number of accolades, including reaching HIMSS Analytics Stage 7 and being Healthcare's Most Wired winner in 2017, as well as a number of other awards that you can see on this screen. So, again, I'd like to thank you all for allowing us the opportunity to tell you about this project that we feel has significantly improved patient outcomes and patient lives by improving depression care. I'm going to start by talking a little bit about the importance and significance that depression has in the United States and in North Carolina. Major depression is one of the most common mental health disorders in the United States, affecting 6.2 million adults and 3.1 million adolescents aged 12 to 17. In North Carolina, over 500,000 people have a diagnosis of major depression, one of the highest rates amongst other states. We know that major depression can severely limit one's ability to carry out major life activities, such as taking care of oneself, taking care of their families, and having productive employment, and managing their own chronic illnesses appropriately. We also know that treating depression appropriately and comprehensively is one of the toughest challenges facing primary care physicians and behavioral health professionals. There are a number of reasons that make improving depression care challenging. First is that it is mainly an internalizing illness, meaning that it's not easily seen by others. It's often silent and easily missed. Depression by its very nature is hard to see, and without routine screening, we will miss it. Second, studies have shown that depressed patients don't come to clinic. Depression by its very nature causes decreased motivation and energy and causes people to become disinterested in their care. And people with depression tend to not show up for their clinical appointments and can be hard to follow clinically and treat. Third, unlike many other chronic illnesses and symptoms, patients don't complain of their depression. They usually complain of other symptoms like headache, fatigue, and pain that occur as a result of feeling depressed. This makes it more difficult to identify. Once you overcome the challenge of screening and identifying the patient's depression, the next challenge is improving their symptoms and quality of life in a healthcare system that has limited mental health resources with long waits to see psychiatrists and therapists that may also be cost prohibitive to the patient. There's clearly a need to have a systematic process that identifies patients with depression and treats these patients with the goal of improving their symptoms by providing evidence-based care and increasing access to mental health resources. I want to take a moment and show you some examples of the PHQ-2 and the PHQ-9 questionnaires we used for depression screening and management, as well as the P4 questionnaire, which assesses suicidality risk. We will be referring to these throughout the presentation. As I've just alluded to, providing quality, comprehensive depression care is a multi-step process that involves screening, treatment, improvement of depressive symptoms, and ultimately depression remission. We address each of these steps one by one in a systematic and comprehensive way so that providers and staff were comfortable with each step and to avoid overwhelming anyone. It is our view that it's very important to get each step right by engaging in a vigorous process to ensure accuracy and usability. Screening is done through the administration of validated and evidence-based questionnaires such as the PHQ-2 and 9 in order to correctly identify the patients that should populate the depression registry. We measure this by percent questionnaires administered. Treatment is measured by the presence of documentation of regular counseling by a behavioral health provider or psychiatrist and or the use of medications to treat the depression. Improvement of these depressive symptoms is measured by utilizing the PHQ-9 to objectively measure change in symptoms by looking for clinically significant improvement, which is defined as a reduction of 50% from the index PHQ-9 score, and a response, which is defined as a reduction of 5 points from the index score. And then ultimately depression remission, which is defined as a PHQ-9 score less than 5 within 1 to 15 months from the index score. In July of 2014, our depression screening rate was about 7% across our primary care clinics participating in the Learning Collaborative. For reference, the PQRS benchmarks for depression screening were 22% in 2012 and 46% in 2013. Screening everyone on a regular basis is clearly important because depression often goes undiagnosed. In 2016, we began looking at how we were doing with the treatment of depression. Our rate was around 71%. Since improving the quality of life of our patients is our overall goal for improving depression care, we took a look at how well we were doing with treating our patients with known depression. In 2016, our response rate, which again is a 5-point reduction, was 38%, and clinically significant improvement was around 50%, which is a 50% reduction. It was around 29%. Now Annie will talk to you about the design and implementation of our tools to improve depression care.
So our efforts to improve depression care was driven by our Primary Care Improvement Collaborative. The Primary Care Improvement Collaborative, or PCIC, is a group where all primary care practices participate to set priorities, develop best practices, measure results, and share improvements. All participating practices are given improvement resources and coaching to help them. Again, we share best practices, learning, and ideas, and we spread what works. We have groups that help set priorities and direction for all of primary care, and we develop measures that matter and goals that push us in the right direction. PCIC's governance structure and framework helped provide us with direction and support. The PCIC Executive Committee approved our depression care quality improvement work along with the accompanying IT solutions and measures. The PCIC framework is used to support the development and implementation of these solutions. So you can see on the left a diagram of how the governance structure works and the various committees that report up through the executive team. On the right, you can see a description of the framework and approach. Our primary care physician and specialist subject matter experts were involved at every level, and they help provide ongoing clinical input and guidance. The PCIC executive and measures committees help set the improvement priorities. They also report back up to a system-level quality improvement group called PPMC, and they also help, as I said, set the direction for the Population Health Solutions and ISD Healthy Planet team, which are the groups that develop and build the IT solutions. That then rolls down to the improvement and implementation teams who work on the ground to support the clinics in using these solutions. Here we're showing a timeline of how our different solutions progressed with time. So across the top you can see the various IT solutions, And on the bottom, you can see how this lines up with the measurement goals that the Primary Care Improvement Collaborative set. So in February of 2015, we began our depression screening pilot work. Shortly after that, we launched the BPA for depression screening in all PKIC clinics. Then we worked towards depression treatment. Again, we did a pilot. In July of 2015, we did some work with developing reports so that care managers could find high-risk depression patients in reports and reach out to them. And then in November, we released the depression treatment BPA to all clinics. Along the bottom, what we show is that in 2014, depression screening was a core measure for PKIC, meaning that all clinics were trying to attain improving their rates and reaching the depression screening goal. In 2015, groups were still working on that, and depression screening was the focus, but then we introduced the idea of a depression treatment measure, and that became a test measure. In 2016, depression screening was a core measure, and treatment, again, was a test. And then in 2017, we elevated treatment to the main measure, introduced the idea of depression remission as a test measure, and then really kind of moved depression screening to a watch measure because people were doing very well. This fiscal year, remission has become the core measure for PKIC. Treatment and screening have been moved to watch measures. Before building any of our IT solutions, we outlined the desired action for each scenario. And again, we relied on our primary care and psychiatry subject matter experts to assist with this process. For depression screening, we're targeting patients who are not already in our depression registry. The action we want to happen there is for someone to administer the PHQ-2 annually to these patients. And if the PHQ-2 is positive, we want to ensure that a full PHQ-9 is administered. For depression monitoring, we're targeting patients who are already in the depression registry. They either have existing or have a recent history of depression. For these patients, we want to administer the full PHQ-9. And we determine how frequently that happens based on the severity of the patient's last PHQ-9 score. We also want to make sure when we're administering the PHQ-2 and PHQ-9 that if we have patients with incomplete screens, that we prompt the user to ensure that they complete the full screening indicated. Last, if we have patients who answer positive to the last question of the PHQ-9, which asks of whether the patient has thoughts that they would be better off dead, we want to ensure that we assess whether the patient has passive versus active suicidal thoughts by asking a question of self-harm. And if the thoughts are active, indicate active suicidal ideation, we want to administer the full suicide risk assessment, or the P4 screen. To do this work, we leveraged our standard process to identify, build, and deploy the right IT solutions. We have operational, clinical, and IT teams that work together regularly to develop value-added tools and resources to improve care delivery. Some of the groups involved here would be our clinical stakeholders, and in this case, it would be our Primary Care Improvement Collaborative. Practice Quality and Innovation, which is the department I work within, and our groups help gather requirements for the analysts and work to help deploy the new content. And then we have Information Services Division, where the application analysts are, who help develop, plan, and execute the build within EPIC. On the right, you'll briefly see the process of how this is done. First, we work to identify the needs and determine priorities. Then we gather requirements from the clinical and operational subject matter experts. Then we work to translate those into EPIC build specifications. Next, we develop a plan and we execute the build within EPIC. We provide training and implementation support for the release. And then we drive process improvement via pilots and improvement projects, and also gather feedback so that we can optimize the build. So first, we built the best practice advisories to promote screening and monitoring. So the goal here is to identify patients due for depression screening and monitoring. The first BPA that you'll see on the left alerts users if a depression screening has not been performed within a year. The second alert will let the user know that a depression screening, a full PHQ-9 has not been performed on a patient who is already in the depression registry within the appropriate time frame. And this BPA references the last PHQ-9 score to determine when to prompt the user. We also created a BPA to alert the user that the patient has an incomplete screen. So here, this BPA alerts the user that the patient screened greater than or equal to 3 on the PHQ-2, but there's no PHQ-9 documented, and this is considered an incomplete screen. So the user can then administer the PHQ-9 and close the loop. Next, we built BPAs to support the completion of the suicide risk assessment. This identifies patients who are due for and assists with completing the suicide risk assessment. We actually have 2 separate BPAs that support this process. On the left, you can see actually both of these are critical pop-up alerts. The first on the left, you can see, tells the user that the patient answered positive to the 9th question of the PHQ-9, but has not answered an additional question that asks the patients whether they have thoughts of self-harm. And this helps assess whether the patient has passive versus active suicidal thoughts. On the right is our second critical alert that tells the user that the patient does have active thoughts that they might harm themselves, and they now need to administer a full P4 suicide risk assessment. So now we also wanted to identify the gaps in our process. Why are patients with active depression not in treatment? So once we had ideas of what we wanted to do for screening and monitoring, we wanted to make sure we addressed the patients with known depression. So some of the gaps that we identified when we did this exercise were, 1, a provider lack of awareness of depression severity. As Dr. Reddy alluded to, depression is often overlooked due to more pressing medical needs, or the nurse could administer the PHQ-9 and not communicate with the provider. Some possible solutions that we developed to address these were alerting the provider to patients who have moderate to severe depression and are not in treatment, and encouraging nurse-provider communication about PHQ-9 scores. Another gap we identified was lack of awareness of outside behavioral health or psychiatry visits. Many patients get behavioral health counseling with providers who are outside of our system, and we may not know that information because we can't capture it within our EMR. A possible solution for this was to create a field to document these outside behavioral health or psychiatry visits. And down the line with some of our external data efforts, we did end up working to capture these outside behavioral visits when we could. Some other gaps were underuse of internal behavioral health resources, patient resistance, and lack of coordinated care, but we didn't directly address these with our projects. So with this, we developed a BPA to identify patients who were not being treated for depression. So this BPA alerts providers to patients who have moderate to severe depression, and that's defined by having a most recent PHQ-9 score greater than or equal to 10, and the patient is not currently in treatment, meaning they don't have an antidepressant on their medication list, or a documented encounter with a behavioral health counselor or psychiatrist in the past 6 months. And the BPA allows the user to address some of the external data and provides orders to prescribe medications or place referrals. We also develop reports to support ongoing monitoring and action. Once a patient is in our depression registry, providers and clinics can run registry reports to monitor and take action on their high-risk patients. So what you'll see here is an example of one of our actionable reports where you can find all your patients who are in the depression registry and further stratify them based on their depression composite score. And the depression composite score contains multiple components that might tell you whether the patient needs extra support or attention due to their depression. The other benefit of these reports is that, as I said, they're actionable, so you can jump directly from this report into the chart and continue to work either calling the patient or reviewing their case. We also held several work groups to support the integrated behavioral health model. So the goal here was bringing together licensed clinical social workers from multiple primary care clinics to develop and spread population-based interventions. So the idea was to teach the LCSWs how to run these reports and use them to take action on some of their high-risk patients. And from the work groups, they developed standard work for the LCSWs to use these reports. So some examples of some of the interventions they took were to run those reports and find patients lost to follow-up. So in this case, you would be filtering on patients with high PHQ-9 scores who don't have an upcoming follow-up visit. Another intervention you might do is to actually find patients who have recently seen their provider for depression and review the visit notes and have the LCSW follow up with the patient on any treatment changes, such as starting a new medication or reviewing side effects. So we used PDSA cycles to evaluate and improve our tools, such as our BPAs. So for our pilots, we used Plan, Do, Study, Act cycles, which are simple QI tools, to ensure that the new BPAs were working as expected. After that, we did local PDSAs performed by the clinic quality coaches to improve utilization and adherence to these new workflows. So at the top, you'll see how we conducted the pilot PDSAs. So for the beginning portion, we selected PKIT clinics to pilot test the BPAs. And the goal here was to ensure they were correctly firing for the appropriate patients and test the workflow, and importantly, to get feedback from some of the users. So we released these BPAs to these pilot clinics and then did weekly or monthly check-ins to gather their feedback. And a typical pilot would last somewhere from 1 to 3 months. Then we would run reports in Epic of the BPAs fired, document any issues, and correct the build within Epic if we needed to. Last, we would determine whether to release these BPAs to all PKIT clinics or whether we needed to go back and refine the build and continue the pilot. If we were ready to move forward, we would coordinate with ISD training for tip sheets and with our PKIT groups for the next steps. Once the BPAs were in all the PKIT clinics, then we would perform local PDSAs. So in this case, we have the primary care improvement collaborative quality and clinical implementation coaches who would perform a local PDSA with the clinics that they support. And here, these coaches are going to tailor their improvement work to the local issues of each clinic. For example, within the collaborative, we have academic and community clinics. We have clinics of different sizes and different staffing ratios. The availability of local behavioral health and psychiatry resources could be different from clinic to clinic, and the patient population could be different from clinic to clinic. So here, the coaches can really target their improvement work based on the needs of the clinic. So they would perform these PDSAs to help improve depression care. Some of the work that they did here would focus on communication and education around the EPIC functionality, making sure they know the BPAs are there and that they know how to use them. They would work with the clinics to identify the local needs and then focus their work on a particular PDSA cycle. And then the coaches share what works and funnel that feedback back to the technical teams to work on optimization. So on the bottom here, you can see some of the outputs from the coaches and the local work. For communication and education, you can see an example here of what the clinical implementation coaches put out, which is called a EPIC Super User Hot Topic. So it's a very slimmed down version, gives you just what you need to know. For the PDSAs, the Plan, Do, Study, Act cycles, what we have here are some screenshots from presentations where coaches and people from the clinics came to a monthly meeting and shared what they learned through their PDSAs so that other clinics can use those best practices. And last, with feedback and shared learnings, we've got an example of our monthly PKIC newsletter, which has highlighted an example of a depression project that turned out to be successful. We also have a PKIC dashboard that helps clinics and providers drill into their depression care data. So our EPIC at UNC quality measures, while displayed in an EPIC dashboard, are also displayed in a Tableau dashboard. This allows more advanced views of the data, such as number needed to meet goal and trend lines. The providers have unblinded data to compare themselves to other providers, to other clinics, and to other entities. And this dashboard is heavily used by PKIC leadership and within the clinics to drive their improvement work. So our aim was to identify patients with depression, to treat depression and improve symptoms. Our first goal was to increase depression screening rates for patients not already in the registry. The second was to increase depression monitoring rates for patients who are in the depression registry to ensure we're monitoring their symptoms. We wanted to increase the percentage of patients with moderate to severe depression who are actively being treated with antidepressants, counseling, or psychiatry. And really, our overall aim is to make sure we're leveraging these tools to decrease depressive symptoms in our patients and ultimately improve their quality of life. So now I'll cover some of the workflows in a little bit more detail. So here we're showing how the depression screening tools are embedded into the clinical workflow. So for screening, the first step is really utilizing our EPIC registries to identify patients with depression by PHQ-9 score, by billing diagnosis, and problem list diagnosis. Then whether the patient is in the registry or not determines whether the user will see a prompt for a PHQ-2 or a PHQ-9. And what you can see here in step 2 is an example of the BPA that would show for the user. The BPA provides a link to the PHQ flow sheets. The user would enter the responses into the flow sheet, or they could choose to defer the BPA if something more urgent was going on during this visit. And once they either defer or complete the flow sheet, the BPA would disappear. An additional BPA would fire if they generated an incomplete screen or needed to complete a suicide risk assessment. And here we're depicting that example. So in this case, the BPA is prompting the provider or nurse that the last PHQ-2 was positive, but the PHQ-9 is missing. And in this BPA, the user can go directly to the PHQ-9 link, enter the responses into that flow sheet, and close the loop. Again, they could defer the BPA if something urgent was going on during this visit. Here we're showing the workflow for closing the loop on depression screening when suicide risk is an issue. So in this case, a critical pop-up alert would tell the user that the last question of the PHQ-9 was positive, but the self-harm question was blank. And just to add some additional detail here, for these critical BPAs, they both pop up within the workflow and also show up within the navigator. So, and these are the only 2 BPAs that we have to do this because of the safety issue. The BPA takes the user back to the PHQ-9 so they can answer the last question about self-harm. If thoughts of self-harm is positive, a second BPA will alert the user to administer the full suicide risk screen. And that BPA will take them to the full P4 suicide risk screen. And really, these BPAs are intended for providers to be assessing. The provider could complete the P4 screen using the flow sheet, or alternatively, they could use a dot phrase to document the suicide risk screen. Based on the outcome, the provider would then take action based on suicide risk protocols. And during our implementation, we really urged all clinics to review their suicide risk protocols and make sure that they were up to date. Here we're highlighting an example on how one of our suicide risk BPAs helped to save a patient's life. This is a testimonial from an internal medicine physician. She was precepting in her clinic, and a resident went to the patient's room to perform a procedure. When the resident and I were reviewing the chart together, the red P4 suicide risk BPA popped up. We reviewed the last note. The patient had been referred to outside psychiatric resources at that visit. She had a PHQ done at her last visit with a positive question to number 10 indicating active suicidal thoughts, but no P4 was completed. We returned to the patient's room to perform the assessment. I said hello to a smiling, cheerful woman sitting with her husband. 20 minutes later, the resident and nurses returned to the precepting room, and they were shocked. The woman had no indication of depression. This woman with no indication of depression reported that since a major illness 3 months prior, she had thought about suicide daily. Further, she had a plan for self-harm. She was crying in the exam room and was scared for her safety and was asking for help. No one saw it coming. There were no clues or signs. There was only the P4 BPA. Because of the BPA, we were able to provide her with the help she needed, likely preventing a suicide attempt. Last, this is the workflow for closing the gap on depression treatment. In this case, the BPA prompts the provider that the patient's last PHQ-9 score was greater than or equal to 10, and as far as we can tell, the patient is not in treatment. From the BPA, the provider could document an external behavioral health visit or psychiatry visit if the patient is getting this care outside of our system. If the provider enters a date that is within the past 6 months, the BPA will be satisfied. Additionally, the provider could access a smart set from the BPA and order an antidepressant, place referrals for behavioral health or psychiatry, or request a follow-up appointment. So the BPA provides them with the follow-up actions that they need to take. The BPAs are prioritized by color and presented in the Visit Navigator. So what you can see here is a screenshot of how the best practice advisories would display to a provider. The BPAs are presented in the Visit Navigator in the Plan section. Color coding indicates priority level. So you can see here the critical alert is in red at the top, high priority is in orange, next is medium priority in yellow, and then low priority shows in green. As I mentioned before, the critical BPAs would pop up in addition to this navigator view to really ensure we're getting the attention of the user. And as I mentioned before, the user can choose whether to address today or defer the BPA by clicking the acknowledge reason, and we typically configure those to have short time frames so that the BPA will come back up in typically 6 to 8 weeks. And what we have here is a high-level process map that shows how our clinical decision support ensure that we do complete depression screening and assess suicide risk whenever it arises. So now I'll hand it back to Dr. Reddy.
So we're going to talk a little bit about what we've achieved so far. As a result of leveraging our IT solutions, we have seen a significant increase in our depression screening rate from about 7% to 76%, which includes about 49 practices and 184,000 patient lives. And a rise in the percentage of patients being treated from moderate to severe depression from 64% to 85%, representing about 7,000 patient lives. As a result of better screening and better treatment, we are doing much better at decreasing the burden of depression symptoms. Response rates increased from 38 to 48%, and the clinically significant improvement rates increased from 29 to 37%. At first glance, the increase in these may not seem large, but it's important to remember the various challenges that I discussed earlier that primary care doctors run into when treating depression, which makes it more difficult to move the needle on depression care. It's not as simple as lowering blood pressure by using a medication. Even after identifying these patients and using various resources and interventions to treat these patients through an evidence-based approach, there is no guarantee that the patients will follow up or engage in the interventions because the very disease itself can prevent patients from engaging in a therapeutic relationship. As a clinician, these increases are definitely exciting to see because it means we're significantly improving the quality of life of these patients. The importance of this cannot be overstated. These are patients who are now able to live more productive and meaningful lives both at home and at work and take much better care of their own physical and mental health. As an example, in just my clinic, the introduction of all the IT solutions has led to a redesign of how we approach depression care. We are embracing team-based care by having our nurses administer depression screening questionnaires and pulling screening out of the provider's hands. We have 2 licensed social workers that are embedded in our clinic on site that run Epic Workbench reports to identify these patients that need PHQ-9s for screening and for monitoring. Once screening rates improved, we realized that we needed better access to mental health resources, so we also embedded a psychologist in our department so that many of these patients could get therapy. Due to limited access to psychiatrists, we also embedded a psychiatrist that sees patients on a consultation basis once per week in our clinical space. We also provided access to behavioralists once per week for consultations. The IT solutions that UNC has introduced has truly allowed my clinic and myself to embrace comprehensive depression care through a team-based approach. So what are our next steps? We want to go beyond primary care and release our BPAs around depression screening, monitoring, and treatment to additional specialties so that we can provide more systematic quality depression care across the entire healthcare system. We have released this to psychiatry and behavioral care, geriatrics, including adolescents and pediatrics, and family medicine, and coordinating inpatient screening and assessments with our ambulatory clinics. Additionally, we are now focusing our attention on depression remission. This has been elevated to a fiscal year 19 PCIC core measure and a UNC organizational goal. We were actively engaged in developing and piloting IT solutions and optimizing clinical processes. We've seen a modest increase from 18 to 21% in the past 1 year. We also know that this will be one of our hardest measures to move for all the many reasons I've listed previously. But I also know as a clinician that engages this population on a daily basis that even a 1% change has huge implications from a quality of life perspective and on downstream improvements in other chronic illnesses that we treat. I believe that as we further embrace and support an integrated behavioral health model, we can continue to see improvements in remission. We are brainstorming additional ways IT solutions can help address clinical inertia, complex patients with comorbid conditions, and ensuring proper follow-up. We are looking at ways to better present a summary of depression care to the end user, providing standardized evidence-based treatment algorithms at the point of care, additional reminders for off-schedule PHQ monitoring, and targeting subsets of the population. Finally, once potential solutions are built, we will pilot these through our PCIC clinics using the PDSA cycle that Annie referenced to determine which solutions warrant further testing and or implementation. Thank you very much for taking the time.
So we would like to thank our speakers from UNC Healthcare today for joining us and presenting their Davies use case. I want to remind our listeners where to go find this and more important Davies use case webinars. That information can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for listening and have a good day.